So what I would like to do in the next 20 minutes or so is pick up where Ro left off, one of the big dilemmas and uncertainties that we've been kind of talking about and working on over the last year or two is, could we enhance treatment anymore by giving more treatment after maintenance therapy? So this just applies to, at the moment, to children with high-risk neuroblastoma. And here we've got the current paradigm of treatment, which, as Rose said, is very similar on both sides of the Atlantic, with induction chemotherapy to try and reduce the bulk of disease, high-dose chemotherapy with stem cell rescue to try and consolidate that, surgery and radiotherapy to control the primary tumour, and then a period of immunotherapy and retinoic acid to try and mop up any cells that are left after all that treatment, and also the retinoic acid to try and differentiate into more mature neurons any cells that are left. The subject of this talk is whether we can build on that and improve outcomes of children more by giving further treatment after this long period of intensive therapy. So really to set the background for that, we need to think about what the outcome of children are when they finish treatment rather than at the beginning. So as Rose said, for children who are newly diagnosed with high-risk neuroblastoma, around about 50% of children will be cured in the long term. However, this graph here is the same sort of Kaplan-Meier curve that Rose showed before with the event-free survival, so the percentage of children who don't relapse on the y-axis, is taken from the end of treatment when children have got through all the hurdles of that high-risk treatment, their induction, high-dose chemotherapy, immunotherapy, and have had a good response to that. The children at the top in the blue, the navy blue line, is the children who have achieved a complete remission with that treatment by the start of immunotherapy, and that shows their outcome, event-free survival from the end of treatment. And for those patients who have been in complete remission at the start of immunotherapy, their 5-year chance of not relapsing is about 80%, which is substantially better than at the beginning and at diagnosis because they've got through all those hurdles of treatment. The red line is those children who hadn't achieved a complete remission at the start of immunotherapy, so still had some disease on scans. And you can see that the event-free survival for those children is lower, but still many of them are long-term survivors. So it's important for any new treatment that we look at that comes after the current treatment, we're comparing it to these figures rather than the 50% figure or numbers in that ballpark that we talk about at diagnosis. And that can be really difficult for several reasons. When children reach the end of treatment, they haven't got any disease to measure and monitor. And for any individual child, although we know if you look at all children, that's the outcome, you don't know what will happen to that child. And when you give a treatment to the child and there's no disease to measure on scans, all you're looking for is whether the disease comes back. There's nothing to shrink in terms of tumour that can reassure you that the drug you're giving is having some benefit. The other thing that makes it challenging is that when relapses do occur, they often happen in the first few months after treatment, and so the starting point for where you start any new treatment at the end of the kind of current maintenance treatment is really important, because if you don't start that treatment till a few months, say 3 months after you've finished current maintenance therapy, even by then the prognosis for that child is better than at the exact time point they finish treatment if they've not relapsed during that time. So the further time goes on, the better the prognosis gets. So the exact time point that patients are recruited to any post-maintenance trial to look for whether such a treatment works is really important to assess whether it's of benefit. So the question that we have faced is, can we improve those percentages anymore by giving a further period of treatment after finishing anti-GD2 immunotherapy? And there's been two things that have been investigated most internationally. The first is a vaccine. It's a bivalent, so it targets two different things, GD2 and GD3. It's the same GD2 that's used in the GD2 immunotherapy. And the aim of that is to to make the child make their own GD2 antibodies by immunising the child, and then DFMO. And I'll talk about both of those and what the evidence we have for each of those is in this setting. So firstly, the bivalent vaccine. So the scientific rationale for this is very strong, that if you can, that we know that antibodies work, they don't cure all children, they improve outcome but don't improve all children, and then we know that the more antibody you give, probably the better that is. And the rationale is if you can immunise, the body makes their own supply of antibody, and then you have permanent low levels of antibody giving the child their own immunity to the neuroblastoma. In the antibody that's been tested has been developed at Memorial Sloan Kettering in New York, and it's given with other things as well as the GD2 and GD3 to try and boost the immune system, to try and make an effective immune response. The GD2 and GD3 molecules are not easy things to immunise with. They're different from bacteria and viruses, which are using the standard vaccines, and so they need to be given with other things to make them effective as vaccines. And in MSK, they have used it with beta-glucan, which is a product that's taken by mouth that is derived from yeast, and sometimes with GM-CSF, which is an injection to boost the immune system. And what they have done in MSK is given multiple doses of the vaccine, initially over a period of a year, but now that's been extended, and they give booster doses up to a total of 3 years with the beta-glucan to boost the immune response. The largest study that they have reported was in children who had relapsed from their high-risk neuroblastoma and then got back into a complete remission. And so that is already a slightly a selected group of patients. So not all children with who have high-risk neuroblastoma that relapses will get back into a good complete remission, and so we have to bear that in mind with the percentages that we see there. They're not survival percentages from the point of relapse; they're from the point of having achieved a complete remission and starting the vaccine. And what they did show with the vaccine was that there was very minor side effects, so sore arms, some temperatures when the vaccine had been given, but generally it was very well tolerated. They were also able to demonstrate that the majority of children who had the vaccine, about 80%, had good immune responses to it. So you could measure the antibodies in the blood of the patients. But what has been more difficult to show is whether the vaccine is actually effective, and that's for all the reasons that I've said, that all of these children are in remission at the point of having the vaccine, and we don't know what the outcome of those children would be if they'd not had the vaccine. So there's not a really good comparison group to say that the vaccine is better than not giving any more treatment. The percentage survivals that they report from this study were very good. So with overall survival rates of 88% at 2 years and progression-free survival of 45% at 2 years in children who had relapsed. But again, this is a selected group of patients who have achieved another complete remission having relapsed. What they did show is that in those children that were treated, those children who developed a good antibody response did have a better survival, which does support the hypothesis that if you can generate an immune response, then it's beneficial. But all of the children in the study were given vaccine, and so there isn't a good comparison, so we don't have any definite evidence that this is improving survival, but the scientific rationale is there and it is safe. So the vaccine is still being trialled at Memorial Sloan Kettering, and I think they have 2 trials open at the moment, both for patients who have completed first-line treatment or have achieved a complete remission after relapse. Patients have to be in complete response when they're given the vaccine. If they have MIBG-positive disease, that has to be PET negative, so they can have some MIBG spots, but they have to be PET negative, and they have to be within 6 months of finishing any other treatment. And in the trials that are happening in MSK at the moment, I think it's been given with beta-glucan and GM-CSF, and those are all single-arm trials where all children get the vaccine, and it's only available in the US. So the alternative treatment that has been most explored in a post-maintenance setting is DFMO, which is also known by these other names. It's a tablet that is taken by mouth. and it's a tablet that inhibits ornithine decarboxylase, which is a complicated part of a complicated molecular process that happens in cells to generate polyamines. And that process can be overactive in patients with neuroblastoma, particularly those that have MECAN amplification. And the idea of this DFMO is that you block that enzyme, reduce the polyamines and starve the neuroblastoma cells of the polyamines. And in the laboratory, that this approach has been shown to slow the growth of neuroblastoma in test tubes and in mice. It's a well-known drug in other contexts. It's been used since the 1970s for sleeping sickness in Africa, and it's been shown to kill the sleeping sickness parasites. And it's been investigated more recently as to whether it has a role in controlling neuroblastoma. So the largest trial that's been done for this was done by the Beat Childhood Cancer Trial, which ran between 2012 and 2015. And this, again, all patients got the treatment. All patients were in remission when they received the treatment, so it's very difficult to know whether it was having any direct effect on any tumour cells. About 100 of the patients treated had just finished first-line treatment and were in remission, and 39 patients had achieved a remission having had a relapse or refractory disease. And patients who were recruited had to have achieved at least a partial response to previous treatment, and any disease that was left had to be PET negative. And they had to start treatment within 4 months of treatment. In the trial, the treatment was given, the DFMO treatment was given by mouth twice a day for 2 years, and all patients received it. There was no randomisation. And again, they reported very good survival figures. For frontline patients, the 2-year event-free survival was 84%, and overall survival was 97%. But again, you have to put these in the context of these were patients who've completed their frontline treatment, were in remission, and so you have selected a better population of patients than at diagnosis. For relapse and refractory patients, they also reported very encouraging survival rates rather than response rates. In the trial, the DFMO seemed to be very well tolerated. The majority of patients in the trial completed the 2 years of treatment, which kind of suggests that it was tolerable and patients managed to take it. Of the 101 patients who had who'd finished frontline treatment, the 79 of them completed the 2 years of treatment, and only 5 who didn't stopped it because of parental choice or of side effects. The others had stopped it because they'd had a relapse of their disease. About 2/3 of the patients who were on the trial reported no side effects at all. And the side effects that were seen were generally quite mild. The main side effects were some liver toxicity with high levels of liver enzymes in some patients. But in general, these were mild, and dose modifications, so reduction in the dose of the DFMO was only needed in 2.5% of patients, and only 1 patient had to stop the DFMO completely because of problems with their liver function. It can cause mild nausea and diarrhea, but generally this is tolerable, and children were able to continue the DFMO. It can cause low blood counts, but again, it was rare in the trial to have to stop or reduce the dose of DFMO because of this. Probably the side effect that has caused the most concern has been hearing loss. And as Ro mentioned, a lot of patients who have been through high-risk neuroblastoma treatment have hearing loss anyway because of the amount of cisplatin treatment is in the treatment. But in the trial, they reported that 7% of patients required a hearing aid after or during the DFMO treatment who didn't at the beginning. And I think about 12% there was some deterioration in their hearing during the course of the 2 years. But in most patients, in I think 9% of the patients, this was reversible when the DFMO was stopped. But it is something to be aware of. So there are no randomised trials of DFMO. We just have this trial where it was given to all patients, which makes it difficult to interpret the data. But what has been performed is a matched comparison, so not a randomised trial where children are randomly allocated to a control treatment or the DFMO, but the children in the DFMO trial were matched with similar children in the main COG trial that ran at the same time period to try and match the individual characteristics of the children who had DFMO with those who'd been treated in a parallel trial where children were not getting DFMO. This is not the optimal way of assessing to get definite evidence of whether a new drug works, but it was the best that could be done with a single-arm trial. And what this showed with this really complex and thorough analysis, the blue line at the top is the event-free survival of those children who'd had DFMO within the trial, and the red line below is those who had who didn't have DFMO and were treated in the other trial. And it showed a roughly 12% difference in 2-year event-free survival between the two. But it has all the caveats of this wasn't a randomised study and is subject to all the risks that brings. On the basis of that matched analysis, the DFMO was approved by the US Drug Agency, the FDA, in October 2023, and it is now available in the US. In Europe, the company Norgine has acquired the drug and is applying for approval from the UK and European drug agencies, the MHRA and EMA, and those are still being reviewed and we don't have the outcomes of those yet. While that is taking place, Norgine have started an expanded access programme to make, in the UK at the moment, to make DFMO available free of charge to patients through their programme, pending the MHRA EMA approval. For patients, so patients in the UK can currently access DFMO through that route. It has to be within 4 months of finishing standard treatment. And patients have to have had at least a partial response to multimodal therapy. They don't need to be PET negative, they just need to have had a partial response, which is in line with the FDA approval label. Within the expanded access program, they cannot take any other cancer treatments, they can't take any chemotherapy, they can't have the vaccine or anything else at the same time. So achieving approval from the drug agencies is the first step to being able to use it as a standard of care. The second step is that there needs to be funding approval in the UK, from the NHS, to show that not just is the drug safe and effective, but is it affordable, and is it the cost of providing it to children in the UK is warranted for the level of evidence is there. And that process, which is called the NICE appraisal, is taking place in April, and they will review all the evidence and make a decision as to whether the drug can be prescribed through the NHS. But the Norgine Expanded Access Programme will run until the outcome of that is pending. We don't have any data about giving DFMO after the European treatment regimen, which is slightly different from the US treatment regimen. And so we will aim to collect information about children in the UK and Europe taking DFMO. In the UK, we've asked hospitals who are giving DFMO to children on the Expanded Access Programme to collect some data about that, about any side effects children get and how children do. And we hope that we can amend the current high-risk trial in Europe, the SIOP and HR2 trial, to collect that information so that we know we can get more information about whether it is of benefit to give DFMO to children in Europe. So the DFMO comes as a tablet. It can be swallowed, crushed or chewed, so it seems to be okay to take, and again most children in the trial managed to take it for 2 years without stopping. There was initially lots of discussion about whether it should be given with a low polyamine diet. In the trial that wasn't enforced, and there wasn't data collected on as to whether that was had any influence on the outcome of children, and it's not part of the FDA approval or the expanded access program that children need to follow a low polyamine diet with. So we don't have any. There's theoretical benefit that if you reduce polyamines even further by cutting them out of the diet, you could improve outcome, but there is no direct evidence for that, and it's not a stipulation of the expanded access program. Children do need to have some blood tests while taking the DFMO. They need to have blood count, liver function tests at the start, monthly for the first 6 months, then 3 monthly for the rest of the 2 years. They need to have hearing tests done at the beginning and then 6 monthly during the treatment. It doesn't influence what scans children need. They can have the normal standard of care scans they would have been having anyway. So I think the question that people are facing is whether their child should take DFMO, should go and seek the vaccine, or should stop treatment. And I think that can be a really difficult decision to make, and there's lots of different things to weigh up. We don't know the amount of data for DFMO is relatively limited, and we don't know what the benefits are for different children with MICN amplification, not with MICN amplification, children with some disease left at the end of treatment. All these different situations, every child is different, and we don't know the benefit for any individual child. It does prolong treatment considerably, an extra 2 years of treatment with more blood tests, injections, trips to hospital, the risks of side effects, having to take a medicine every day for 2 years, and the risk of side effects, although we hope the risk of those is relatively small. For seeking the vaccine, there's also the additional burden of travel and cost. And so, just to summarise, I don't think we can give any mandate as to what families could do or strong recommendation what families should do. That has to be an individual decision for families that their physicians can support them with. But just to summarise what we know about each of those different options, for the bivalent vaccine, we know it's safe, the side effects seem to be mild, it does generate an immune response, and if you get an immune response, that seems to have a beneficial effect on outcome. There's promising data for the single-arm study, but all those patients are in remission. We have nothing to compare that to, and there's no randomised trial. It is a lot of extra injections, and it prolongs treatment, and there is a significant cost and burden of travel for families seeking it. For DFMO, we know it appears to be safe, it's generally well tolerated. There is a small risk of worsening hearing, but we think that improves when you stop treatment in most patients. It does prolong treatment by 2 years. There isn't randomised data, but the data from the matched comparison was sufficiently robust for the FDA to approve it. So there is some level of evidence, and it is currently available in the UK without any cost to families. There is no data at all to directly compare the vaccine with DFMO in terms of helping families to choose one over the other, or neither.